I request Dr. M L Kalra sir to start the proceedings. I hope the speakers will restrict to time. We would like to wind up by, we have 40 minutes, so we would like to wind up by 10:05, and then we have another 25 minutes for question answer. Wind up by 10:30. Friends, ladies and gentlemen, welcome to CME number uninterrupted, continuous 839.
Welcome friends. I am thankful to Physician Forum of India, Dr. Chauhan and its team. Firstly, I want to congratulate Dr. Chauhan for the achievement of his daughter. So, I want to congratulate from all of us. Sir, my duty is very simple. I have to introduce someone whom everyone knows, Dr. Vanita. So this is not first time. I know her for maybe more than 15 years now, and my friends were laughing when I was saying to her that I know you before you know me. So because her fame was more than me, I know her as a electrophysiologist introduced by one of my colleagues. So she will be talking about management of heart failure. We know heart failure is a failure of either pump or filling, maybe structural, maybe functional. So treatment again, maybe medicinal, maybe device. So we will learn many things today from her. What are the newer modalities, newer medicines, and what are the options. So regarding her fellowship, she has been a fellow of American College of Cardiology, Fellow of Heart Rhythm Society, Fellow of European Society, Fellow of Royal College of Physicians, Fellow of Internal Medicine Specialist. To cut short, I would say she is Fellow of Physician Forum of India. So, I know her. She has a very good hand in devices. And of course, medicines are our forte. We are physicians. We are more concerned about how to use medicines more judiciously, what stages and what to give. Of course, question answer will enrich us better after her talk. I welcome Dr. Vanita.
Good evening, everybody. Thank you, Dr. Kalra, for your generous and very kind words. I'm always obliged. You were so humble. I mean, what do I say? It's really nice to be in touch with you. So, I always enjoy coming back to the Physician Forum. That's why I never give up a single chance to miss this forum, because I enjoy interacting with you all. It's a fact that we come and speak here, but every time I have come and spoken here, I have learned a couple of things from you. Because, we as a cardiologist or a cardiac electrophysiologist, we become focused on a single thing, but you see that same thing from a wider aspect. And that is what makes you all special, the interactions that we have, the question answers, things that we have, especially Dr. Tulsi, of course, he gives such good comments and he has fabulous pitara, I would say, with questions, which he knows the answers and he discusses in a very beautiful way. So, wonderful, sir. And I enjoy that, So that's why when I got a chance to come here again, I thought, let's go and discuss heart failure. Now, there have been a lot of advancements in the management of heart failure. But why do we need all these advancements? Why do we keep talking of we need to manage it, we need to more advancements? Well, because the most important thing is that the burden of heart failure is gross. And with every passing day, it is increasing. You all know we are the diabetic capital of the world. And diabetes is the main cause of coronary artery disease. And once the patient has MI, he loses the pump. And once the pump function is lost, the heart failure today or tomorrow will result. And we need to manage this heart failure in time. All the readmissions that the patient has to the hospital for the worsening of heart failure is a huge economic burden. Now in United States of America, everything is paid by the government. But in our country, patient pays from the pocket. So each and every readmission actually costs him 2 lakh, 2.5 lakhs, 3 lakh of rupees, whatever in between these things. And that is not a good idea at all. The mortality, however, stands there. 50% of these patients who become symptomatic with heart failure, they die within 5 years. And severe heart failure, 50% patients die within 1 year. That means class 4 symptoms because of pump failure. Henceforth, we need to be very cautious about it. We need to have more drugs. We need to have more devices. We need to have lifestyle modification. All these factors together have to help us so that the epidemic, India's silent epidemic which is coming because of coronary artery disease being prevalent all over. You must have seen so many youngsters coming with MI nowadays. Post-COVID, there is a huge, surge of youngsters coming. In fact, before that also, because of our lifestyle changes, especially in urban India, the young patients are coming with extensive MI. You see, as young as 25, 27 years old, males, females, the barrier has actually been removed of females being protected from coronary artery disease. That's no longer true. And once these people come with MI, the heart function goes down, and we have to manage them as heart failure patients. So now, how are we different from the West? We have smaller coronary arteries, we have diffuse disease. Once we have MI, it is an extensive MI that we have, and the heart function reduces. So our prognosis is worse. We have high 1-year mortality. Diabetes mellitus, I already discussed. We are the diabetic capital. I think you must be seeing more of diabetic patients than me. Coronary artery disease forms the major contributor, and we have young patients coming with MI presenting with heart failure. Now these patients are looking at what? They are looking at better quality of life and better quantity of life. Younger patients, not the older patients who would be just sitting in the house, watching TV, going to the toilet, and that's all they want. Now the younger patients are having heart failure, so they are looking at better answers so that they can have a better quality of life. It's a silently progressing disease. Heart failure is a silently progressing disease. In all classes, NYHA class 1, 2, 3, 4, we need to target so that we can give a better quality of life to the patient and of course improve in the quantity of life also. Prevention is the best. So all those here who are working on preventive working on the patients for preventive of cardiac events, they are actually preventing not only coronary artery disease, not only MIs, but heart failure also. So if you have a patient who's NYHA class 1, but ejection fraction which is around 40%, 45%, please try to target so that the progression of disease does not occur in this patient, and that is very important for these patients. So at any stage you have to do the prevention of heart failure and then the treatment of heart failure. We have been using various terms: heart failure with reduced ejection fraction, heart failure with mildly reduced ejection fraction, and heart failure with preserved ejection fraction. Now, reduced and mildly reduced, we will not discuss at the moment, but reduced and preserved, they are two different aspects of heart failure which have to be targeted because we are more and more we are seeing heart failure with preserved ejection fraction also coming to us, and they are more of a challenge because their heart function is normal, but still they are going into heart failure. So, but today's topic, I am more keeping it around heart failure with reduced ejection fraction and minimally reduced ejection fraction or minimized reduced ejection fraction. So, what is the clinical phenotype of heart failure? Well, more and more preserved ejection fraction, you will have older patients, you will have female sex, especially syndrome X. You will have patients who have alcohol use, which is very common. There are lung diseases, which are very common. Their heart function is maintained, but they have other factors, combination of other factors, which are giving us trouble. And the patients with reduced ejection fraction nowadays, which are coming, are more of males, younger people with coronary artery disease, diabetes, a valve disease. So this is how the phenotype of heart failure is varying. And both preserved ejection fraction and reduced ejection fraction have similar hospital admission rates. It is not that the one is better than the other. They both have to be targeted. They both have cardiovascular hospitalization, and they both are a burden on the economy that we have. And they have similar high mortality. Both of them. If you get these patients keep on getting admitted again and again, they will have mortality which is very, very high. And respective mortality rates in both the groups are 29 to 32% at 1 year and 65 to 68% at 5 years. So mortality rate is almost the same whether we are talking of preserved ejection fraction, that is more than 50% of ejection fraction on echo, and reduced ejection fraction, that is less than 50% on echo. We initiate the guideline directed medical therapy at the earliest. That is very important. But do not leave it at that. We have to up-titrate the drugs. Anybody more than you cannot tell me that yes, we start with the low doses, we have to go up. And we have to manage the comorbidities. Okay, and ARNI. ARNI over the time has changed our thought process very dramatically. It is a very interesting, very good drug which has come to our armamentarium, and it has changed the management of heart failure in our scenario. We had these trials in the past when ACE inhibitors came in. You know, when I was doing my MD medicine, I finished my MD medicine in '93, and what I was taught at that time was that, you know, when a heart failure patient comes, give diuretics, give digoxin. That's it. We don't have anything else. We just have to improve the symptoms. And look at the way the things have changed over the last 3 decades. We have ACE inhibitors. ACE inhibitors came in as a revolution for patients of heart failure because they improved the quality of life, quantity of life, they did the remodeling, they improved mortality. The mortality decreased dramatically with ACE inhibitor use, and you have to give these drugs as early as possible. The ARBs came along with that. Of course, if the patient could not tolerate ACE inhibitors, we had to give ARBs. Beta blockers. Well, they were contraindication in heart failure patients, and now every patient of heart failure gets a beta blocker to control the rate so that the afterload reload on the patient's heart is reduced because of the rate control, and they improve sudden cardiac arrest in these patients. mRNA antagonists, of course, again have shown mortality benefit. So these drugs over the years, you know, all these trials have shown they are very, very promising. What is new which has come in? Despite these drugs, there is increased mortality, we all know. Now what has changed is ARNI. Now ARNI is a combination of 2 drugs. One is valsartan, one is sacubitril. I'm sure you all have read about this drug and you know about this drug. Valsartan is an ARB, so it works on the RAS system. Well, sacubitril works on the natriuretic peptide system and on the bradykinin system. It causes vasoactive substances, and it enhances, it lowers the blood pressure, increases diuresis, and henceforth it improves. Now we have, I'll just say in a couple of more slides, I'll be showing more things about ARNI which have come across in the trials to come. But it has been a very promising drug because of its mechanism of action, and it has the promises that it has shown. Initially we used to give them as an outpatient drugs. Once the patient is stabilized, sent home, then we would either withdraw. We had to withdraw ARB and start ARNI. We had to withdraw ACE inhibitors, give a 36 hours gap, and then start ARNI. But now Once the patient is stabilized in the hospital, we have enough data that prior to discharge, we should start ARNI, and that gives mortality benefit, that gives survival benefit to the patient, and it is the number of re-hospitalization because of worsening of heart failure are reduced in these patients. Well, the paradigm of heart failure trial was one of the earliest trials of ARNI. It did show that there is a relative risk reduction in the events as compared to enalapril, that is the ACE inhibitor, when ARNI was used in class 2 to class 4 patients. The composite death, heart failure, readmissions, and the list of patients to be put on LVAD, that all reduced along with in patients of reduced heart failure in case the patients were started on ARNI. Reverse cardiac remodeling, this is the most important factor that we look at because the heart is so dilated that we have to reverse remodel it, and ARNI has been very promising. It improves ejection fraction, it reduces the end diastolic and end systolic volumes in the heart, causing reverse remodeling. So, quality of life, of course, Cancer City questionnaire showed a gross improvement in patients who were on ARNI. Now, along with ARNI came in your favorite drugs, that is SGLT2 inhibitors. And these, by chance, they became the drugs who were not only good in controlling diabetes but also improving heart function, and they have actually become so good in patients of heart failure that they showed a mass shift towards patients. Instead of ACE inhibitors, ARB, beta blockers, MRAs, we now start the patients on SGLT2 inhibitors and ARB first. Your beta blockers have taken a backseat, MRA antagonists have taken a backseat, though they should not. I love those drugs also. So you can start all these 4 drugs together now to the patient, and that's what this has been promising, the DAPA HF trial and the Emperor reduced trial with DAPA and EMPA. Both of them have shown marked benefit of patients in heart failure. Now, what are the latest guidelines? What do they tell us? Well, the ESC guidelines, the ACC, AHA guidelines, all of them have put these 4 drugs, ARNI, SGLT2 inhibitors, beta blockers, and MRA antagonists as the class 1 indication of starting in patients of heart failure. Along with that, the management of the guideline for heart failure itself has these 4 drugs as the class 1. And these are the algorithms. So I'll just briefly discuss these algorithms. These are the algorithms which have been suggested on the guideline directed medical therapy. It can be a conventional stepped approach, that means you start 1 drug at a time, and over the next 6 months, you will have all the 4 drugs in the patient. Or you can have rapid sequencing followed by up titration, which means you start 2 drugs at a time, then add the 3rd, then add the 4th. Or you can start rapid titration by starting all the 4 drugs at low doses, and then over the time up titrate them 1 at a time, and the patient will be able to adjust well and improve well. So this is the kind of a take-home message. Well, do not wait for 6 months. I would say pre-discharge, start the patients on ARNI, start the patient on SGLT2 inhibitors. These are all beneficial drugs which have to be given. And in addition to this, get an echo done every 3 to 6 months to assess how much improvement has occurred. Please do look at the ECG of the patient. Now there comes my bread and butter. Medical therapy I can discuss with you, but look at the ECG of the patient, because if this ECG is there of the patient as a left bundle branch block, the dyssynchrony will remain and you will never have the required effect of medical therapy which you want if you have the ECG like this. Now, what do you do in this ECG? Normally, I would say we have to put this patient on a cardiac resynchronization therapy with 3 leads, one in the RA, one in the RV, one in the LV. But you can achieve this narrow QRS with the latest modality that we are practicing, with a dual chamber pacemaker. How can we do that? We do that with left bundle branch block pacing. This is where we place the lead at the left bundle and the narrowing of QRS is most of the time even better than that in the CRT. This is another patient of ischemic cardiomyopathy who did not have a wide QRS, 120 milliseconds only. The indication of CRT comes at 150, but he required 50% of pacing with the ICD. So I had upgraded that patient to actually a left bundle pacing along with a device therapy. So you can use a CRT. In fact, with the instead of LVD, we can put it at the left bundle because QRS is not very wide. It is 120. So we just need the dysentery to be removed and be given the benefit so that he has a narrower QRS. He had a 90 milliseconds, 80 milliseconds, 90 milliseconds QRS at the end of the procedure. Now, right bundle branch block patients, we used to leave these patients. The right bundle branch block is a contraindication with CRT. Now these patients can be targeted with they can be given a narrower QRS with dual chamber pacemaker with left bundle pacing, where we correct this right bundle and give patient a narrow QRS. This is my today's patient, the left bundle branch block, and this is the narrowing after the left bundle branch block pacing. So this is a very important modality. CRT should be done in patients who can afford it, but we should look at the ECGs very carefully and give the patients benefit of left bundle pacing with the dual chamber pacemaker. So, okay. I don't know why it is not moving ahead. Oh, okay. Thank you so much for your patience here. I finished in time.
Yes, definitely.
Thank you so much.
And then for Dr. Viny, right?
So questions now or later?
Later.
I'll take it.
So you have a diastole now. Ma'am, you are welcome, Dr. P K Mangla.
लाइट जला दें
कोई नहीं
Good evening. We have another topic, very interesting, obstructive sleep apnea. We all know there is a spectrum from simple snoring to severe obstructive sleep apnea. It happens in night but disturbs the day. Patients get up, will be dull in the morning. Half the accident on the roads are by such patients. And it deranges sharpness of the mind and lot many more symptoms because of this. The treatment is very rewarding. To the extent of severe obstructive sleep apnea is that doctors have gone off to sleep, anesthetists have gone off to sleep after giving anesthesia, surgeons have slept while operating, and I'm not exaggerating, these are actually the patients I have seen. And engineers, repairing aircraft engineers, they have gone off to sleep while repairing them. And again, half the accidents on the road are by these patients. They say we will not sleep, but it's a moment, I have seen a patient landing up with a cervical injury and becoming quadriplegic, a young guy. So let's hear, and the standard of care, obstructive sleep apnea, dental appliances, and little more, many more things, surgery also. Let us hear from Dr. Viny Kantroo about the subject. She is a senior pulmonary consultant at Indraprastha Apollo Hospital. Dr. Viny Kantroo.
Big hand for Dr. Viny.
Good evening to everybody here with the August gathering. Thank you, Chauhan sir, for introducing us to everybody in the forum here. I am absolutely delighted to be present here this evening with the physicians of India, the representatives of our own New Delhi, who take care of each and every patient and each and every disease. Thank you to all for that. And what better than being moderated by P K Mangla sir. Thank you so much again. So I would be talking about obstructive sleep apnea. Now you would be asking me, why did I choose this topic? It is very, very simple because we had a talk on heart failure today. So one of the causes for heart failure is actually untreated sleep apnea. And sleep apnea is very, very common, especially after we have been now labeled with another medal in a list of already established conditions. So we are the most populated nation in the world, and we are the diabetic capital in the world. We have a lot of patients coming in with this particular condition because of the more population, because of more physician knowledge, and also because of more diabetes, which is getting very, very prevalent in our population. So metabolic syndrome, Z syndrome, X, all these are related, hence I have chosen this topic. We would be talking about briefly about all these things, which is the definition, the disorder, the prevalence, pathophysiology, what are the various mechanisms, how is obesity and OSA bidirectional, when do you suspect, how do you manage, what is the diagnosis, how it is done, and briefly about the treatment part. So typically we have a patient who presents with OSA, it would be middle to about more than 65 years of age, senior executive working in an office, sitting mostly on the chair, whole of his day, having a stressful time, lack of work and good life balance. They don't have any time for themselves. They say they are busy all the time, running around for our work but not running for ourselves. We would be having hypertension, most typically, which has been diagnosed for over a decade. And then on the other hand, after the hypertension has been detected diabetes, and for years on he has been on triple therapy, and now he's not even getting controlled on this triple therapy as well. So BMI is ranging between 30 to, for about 13 to 14 years. He has forgotten to care for himself, and now he is developing excessive snoring, tiredness, sleepiness during the day, and early morning headache, which are all the typical symptoms of having an obstructive sleep apnea kind of a picture. So if we ask ourselves, how common is it? Is it very common? So prevalence has been increasing for the previous years. It is now going up to 20% world over. And if we see these figures, the overall recent studies have shown us a prevalence of 14% in men and 5% in women. I would be telling that this might be an underestimation of the numbers in women, because most of the time women think that the weight gain is postmenopausal and they sometimes ignore it. They also blame these disturbances in sleep on the postmenopausal symptoms sometimes. So we have to be very, very vigilant and ask our patients, particularly these kind of symptoms, if they are developing in their later life. 20 to 30% in the elderly and obese population. Here is a graph which is showing you the overall prevalence. If you see that it has been increasing in every country world over. When do we suspect sleep apnea? So very commonly we see in outpatient a partner coming to us telling us that my husband is snoring exorbitantly in the night, I am not able to sleep throughout the night because I get that sound and I get up. So I have to change my room and sleep in a separate room. A patient having morbid obesity, the first thing which should be coming to your mind, especially these days when the patient is being put up for a bariatric surgery, you should be suspecting obstructive sleep apnea and getting the sleep study done initially, rather than the patient getting complications perioperatively when they are doing such a large surgery such as the bariatric surgery. Uncontrolled hypertension, as we have already discussed, the patient is already on 3 medications but still getting hypertension. Congestive cardiac failure, so this is what I told you about. 11 to 53% in the sleep heart health study, it was shown that patient had been having congestive cardiac failure, and one of the underlying very important causes is obstructive sleep apnea. So patients planned for bariatric surgery, the prevalence of OSA is as high as 70% in this population when you have to particularly get a sleep study done for these kind of patients. So what is actually obstructive sleep apnea? What is happening? The pharyngeal collapsibility is the problem which is leading to the problem over here. We have a patient who is getting problems during the night. Does this work?
Yes.
So we have pharyngeal collapsibility. We see that the pharynx is getting collapsed during the night, especially with the loss of tone of the muscle. So sleep apnea is a type of sleep disordered breathing. We have a lot of types of sleep disordered breathing, wherein we also have certain people with obesity, hypoventilation. But obstructive sleep apnea comes under the gamut of sleep disordered breathing, which is characterized by obstructive apneas, which is complete or 90% reduction in the oropharyngeal thermistor flow. It happens for more than 10 seconds and is accompanied by increased respiratory effort, which can be seen in the leads in the sleep study, which are wound around your abdomen. So pharynx is getting collapsed due to the hypotonia in the muscles during the night. The oropharyngeal airflow with the result is lessened, and hence the patient doesn't get enough oxygen, leading on to the apnea and desaturation spells. It is these desaturation spells which is leading to the problem in the patient. And on the other hand, we also have hypoapneas, wherein there is no complete reduction in the pharyngeal the collapsibility. However, there is 30% reduction in the flow in the peak nasal pressure, inspiratory airflow compared with pre-event baseline, which leads to 3% decline in pre-event saturations or microarousal. So this is what we see in the sleep study also. We correlate with it with patient efforts, as we all say we don't have to particularly stick to these kind of parameters. If your patient is having certain symptoms, they are giving you particular symptoms during the day, they are having hypoapneas, even if they don't lead to this kind of particularly 3% desaturation, but on the other hand, they have this kind of microarousals which are happening, and the effort is a lot on in terms of the patient getting abdominal efforts. You can label these kind of picture seen in the sleep study as hypoapneas. We also have something called respiratory effort related arousal, which is a sequence of breaths for more than 10 seconds, not meeting any of the above reductions. However, this leads to microarousal. So this particularly is to emphasize the fact that don't just confine yourself to these definitions. If your patient is having certain kind of symptoms, which is actually corroborating with your findings in the sleep study, they have more effort-related arousals which are happening during the nights. Particularly, they may not be having the desaturations, which are not able to see on the saturation probe in the sleep study. They could still be having sleep apnea, which is leading to the metabolic syndrome, which is leading to the fluid retention, which is causing excessive hypertension, and which is leading to sleep fragmentation, which is responsible for the chronic inflammation which happens in these kind of patients. Obviously, all the predisposing factors are those of metabolic syndrome, obesity. We have seen 58% of moderate to severe OSA patients are obese. They have adipose tissue deposition. They have lung volume changes, and 10% reduction in weight, on the other hand, sometimes is seen to lead to 26% reduction in the apnea-hypoapnea index. All of these patients might have upper airway anatomic abnormalities, which could be the craniofacial deformities, which can be the cause of OSA in younger population or your adolescent patients which come to you. The tonsillar hypertrophy again in the adolescent and the childhood OSA patients which come to you. Macroglossia sometimes in your growth hormone excess patients. The acromegaly again leading on to these kind of symptoms. The gravity and the body position, the positional OSA which we all know, AHI is seen to be twice as high as in the lateral position. So sometimes sleeping on the sides, patient might not be able to show you the particular AHI required to diagnose these patients. But however, when you see them in your supine position in the sleep study, they have those desaturations, they have those fragmentations in the sleep. When we say that this particular patient needs the CPAP, and this can lead to a better lifestyle in these patients. Genetic factors also are there. We know that family history is important in OSA. We have seen particularly families coming to us with the same symptoms again and again. Endocrine disturbances, OSA is seen in 35% of untreated hypothyroid patients. So don't forget to check the thyroid levels in your patients if that they have not been done anytime in their lifetime. So sleep disordered breathing is found in 70% of acromegaly patients again because of the craniofacial abnormalities these patients have. 70% of women with PCOD might be suffering from endocrine disturbances. For example, the insulin resistance, which is responsible for the fluid excess in the body. It is a complex mechanism, every disease leading to that kind of chronic inflammation, which is the denominator in many of the diseases we see now in terms of lifestyle diseases. Smoking again leading to the inflammation, alcohol and drugs causing excessive sedation, sleepiness, hypotonia. Shift workers worsens the severity of OSA. We have all seen it. This happens because of the fragmentation in the sleep, lack of sleep. Their sleep cycle gets reversed and everything gets haywire for them. So as we spoke about the consequences, somehow the intermittent hypoxia, changes in intrathoracic pressure and sleep fragmentation are the three underlying mechanisms which are causing the problems in your patient. So this leads to sympathetic activity, pro-inflammatory status, oxidative status causing endothelial dysfunction, hypercoagulability, metabolic actions, neuroendocrine changes and hemodynamic changes, which are responsible for a gamut of diseases which can be seen in these patients, which could be ranging from the cardiovascular and cerebrovascular effects, which could be stroke, arrhythmias, ischemic heart disease, heart failure, and pulmonary thromboembolism. Also includes insulin resistance, diabetes, metabolic syndrome. Even now it has been touted that in the long run it could have some neoplastic effects due to the chronic inflammation which these patients have. Of course, we have patients coming to us with dementia and depression which could get worsened with the presence of OSA. If your patient is having repeated episodes of depression which is not getting corrected, sleep fragmentation could be one of the underlying reasons behind it. Increased accidents, which Dr. Mangla sir aptly told us, and diminished quality of life, of course, with this kind of fragmented sleep. We also have barriers to diagnosis. What are certain causes which have been found to be important is general public awareness. Many of the individuals do not recognize the symptoms and the severity of condition, ignoring this condition, especially true for females. Primary care physician education, the frontline caregivers do not routinely ask about duration and quality of sleep, or for that matter depression. Mental health is obviously a very important and very commonly ignored part in this part of the world. So we don't screen our patients for OSA. Diagnosis and treatment, while usually covered by payers for qualified patients, costs average a lot in India also, because the cost of a machine for these patients, simple CPAP machine could be ranging between 30 to 60,000. So that is a lot. Even if you get them diagnosed, they might not be able to use the machine. So these are some of the causes which are barriers to diagnosis and treatment. How do we approach a case of suspected OSA? We ask targeted history, which could be in the form of questionnaires, which we would be touching upon in our further slides. Physical examination, which could be awake and sleep endoscopy, which could be under sleep, that we are watching the patient by giving propofol sedation and we are putting in an endoscope. It could be a laryngoscope also, or we could even be seeing them with the bronchoscope, what is happening to their posterior pharyngeal wall and their tongue while they are sedated. So additional tests which are required is sleep study, of course, and X-ray to rule out any lung causes for hypoxia, and of course we spoke about the thyroid. So treatment includes a multidisciplinary approach. It is not only the device or the surgery or the myofunctional therapies which are important. It is the overall the gamut of requirement of lifestyle changes, treating their insulin resistance, getting their weight down, treating their thyroid function, getting them into physical activity, which is really important. So all these treatments are complementary and fully combinable. So if we have a patient who has low probability, we will expertly evaluate this patient by asking certain questions, and if we find out he doesn't fit into the category, we can keep them under follow-up, and if they improve, then we go on the lines of other diseases. If they don't improve, we of course go for a polysomnography or a respiratory polygraphy if we don't have PSG available at our center. So other sleep disorders should also be suspected. If your patient is having daytime hypoxemia, of course it goes into obviously hypoventilation, where the decision making is important, because it may be that the patient might be requiring BiPAP in place of CPAP. So it has some economic decision making importance in your patient that you are seeing the daytime hypoxemia. Evaluate for anxiety, depression and insomnia, of course, and if your patient has intermediate to high probability, we would directly go in for respiratory polygraphy and the polysomnography examination, wherein we define the patients of OSA with an AHI more than 5. If the patient is having an AHI of more than equal to 5 with symptoms of daytime tiredness, not getting enough sleep during the night, having fragmented sleep, having the extent-prone propensity in them, then you diagnose the OSA in them, and if the AHI is less than 5, then you have to see that they have no OSA, and then if you still suspect OSA in these patients, you might repeat a polysomnography at a later date. So if the AHI, the apnea hypoapnea index is between 5 to 15, we call it mild. If it is more than 15 to 30, it is moderate, and if it is more than 30, we call it severe OSA. These are some of the screening questionnaire tools for pre-test probability. They are very simple, low-cost tools present on just a paper, which you can ask your patients very well in your clinics. They are Viny questionnaire, stop bank, stop questionnaire, and IPPER sleepiness score. So IPPER sleepiness score is basically for your patient only for sleepiness, whether they are getting your daytime sleepiness or not. And out of these, the stop bank and the stop questionnaire are appropriate screening tools which have been seen to be having highest sensitivity and specificity in terms of your detecting the probability of having an OSA. And we have seen, although the sensitivity is high in all these questionnaires, the specificity is not very good. So many of these studies have a specificity which is less than 50%. So this is the Berlin questionnaire, which targets your snoring, which is targeting your daytime sleepiness, as well as the hypertension, which are the three things which are very important in case of OSA. You ask certain questions: whether do you snore, your snoring score is, which is slightly louder than breathing, as loud as talking. So you're asking about how loud the snoring is, and the frequency of snoring, whether the other partner is bothered by the snoring, and then whether some of them have detected any apneic spells in these kind of patients, and about the fatigue and so on and so forth. So you could be keeping this Berlin questionnaire in your clinics very well. This is just to highlight the fact that there are studies which have happened over the predictive parameters of these screening questionnaires. There's many number of studies which have been done. Of course, I have picked up just a screenshot of a lot of studies which have happened you will see the sensitivity is reasonably well, it is more than 50%. However, when it comes to specificity in all the three categories, whether it is mild, moderate or severe, it is mostly less than 50%. So we do not actually get a very good positive predictive value out of these kind of questionnaires. So your clinical assessment is absolutely important to get the diagnosis out of the patient. So the stop band questionnaire had the highest sensitivity for the prediction of mild and severe OSA, which ranged between 97 and 98% respectively. So usually we prefer the stop band and the stop questionnaire. This is the IFPER sleepiness scale to assess the sleepiness of the patient. We ask these questions, how often the patient would fall asleep during the following situations: sitting, reading, watching TV, sitting inactive in a public place, as a passenger in the car. I'm going to skip some of these questions for the want of time. So this is the stop questionnaire where 2 out of 4 is important and significant. You have to ask. It is very, very simple. You can just count it on your tips of your fingers. The snoring, tiredness, observed apnea, high blood pressure. So very, very simple, wherein you can ask your patient and screen your patients for OSA. This is the stop band, wherein in addition to the above parameters, you also ask them about their BMI, their age, their neck circumference, and the gender, wherein we see that male is more predisposed. So this is regarding the OSA severity. Mostly we have seen that the cardiovascular outcomes become more important when their AHI and apnea-hypoapnea index goes higher. So they get more predisposed to cardiovascular diseases. So these are some of the reasons that you should be referring your patients to us. This is the most important slide for me. So referral to a sleep symptoms when 2 or more of the following would be there: snoring, observed apneas, extra daytime sleepiness or unexplained tiredness, at-risk factors, the certain professions which are very, very predisposed. For example, truck drivers or shift workers are very, very prone to OSA, where you would be thinking about it. Incapacitating hypersomnolence, respiratory failure, refractory HBP, difficult to control arrhythmias, which Dr. Vanita often sends to me. She senses that something underlying cause is a cause for their untreated arrhythmia, so she does send the patients for evaluation of OSA. Disease due to uncontrolled OSA, or criteria wherein where these are not met is only one symptom, sign but no symptoms are there. The patient might be showing you, he might be obese, however they have no symptoms, so you may not try to investigate them, especially when they don't have so much of money. So EDS explained by other causes, cardiovascular risk factors associated only with snoring. So standalone snoring may not be as important as other associated factors. So these were some of the factors which need an urgent referral. Herein, you need to send an ordinary referral. Actually, these guidelines are all Western guidelines. It's based on the availability of sleep specialists at their center. So that is why we have this kind of the division.
We need to conclude.
Yeah, please.
Okay, sir. So diagnosis most of the time happens by a sleep study, wherein we apply the EEG leads, we apply the abdominal thoracic leads, which are seeing your excursions of your thorax and your abdomen, and in addition they are seeing your effort. And of course the pulse oximeter, which is there. This is the level 1 sleep study which is happening, wherein you have a sleep technician who is overlooking the work. We have split night and limited polysomnography, the prediction questionnaire. So these are some of the polysomnography, the levels which happen most of the times. We have level 3 and level 4, which are the home studies which are happening these days. I'm going to skip some of the slides. So CPAP therapy is the gold standard as a treatment for OSA. It leads to reduced daytime sleepiness, contributes to weight loss because your patient is getting more motivated towards weight loss because of daytime alertness, better blood pressure control. It may improve metabolic parameters which can be reduced total cholesterol, increased in HDL levels, better glycemic control and insulin sensitivity, and improved endothelial function. Of course, there is improved quality of life, reduction in visceral fats. Whether it leads to a reduction in mortality is still questionable because it may be that we are intervening at a later date. The hygiene and dietary measures are equally important. There are additional therapies which could be positional therapy, mandibular advancement devices, surgical therapy, especially for mild to moderate OSA, where we have found in certain upper airway problems in the patient, especially in childhood OSA, wherein there are certain tonsillar enlargements happening which is causing the OSA. Hypoglossal nerve stimulation is something which is done these days to stimulate your nerves which are there for your hypoglossal nerve, which leads to reduced hypotonia of these muscles and keeps them taut during the sleep, also leading to reduced collapsibility of the airway. So this was in New England Journal of Medicine in 2016, CPAP for the prevention of cardiovascular events in OSA. The primary endpoint was death from cardiovascular event, and about 2,700 eligible adults were seen in the study. It was seen that therapy with CPAP plus usual care as compared with usual care alone did not prevent the cardiovascular events. However, as I told, it may be that we are intervening later in the course of the disease. Weight loss does help in all these patients. I showed you the reduction in the AHI which happens by about 26% in these kind of patients, and it was all proved in many number of trials. Medical therapy in terms of BMI reduction, we have a plethora of drugs which are now available, including liraglutide or listats, which can be prescribed, and your patient could be managed in a better way. Bariatric surgery is well into the arena now. It leads to reduction in all-cause and cardiovascular mortality. It leads to basically significant and important, and it has been seen that 35% of bariatric surgeries versus 13% nutritional therapy were able to discontinue PAP therapy for obesity hypoventilation. So take home is suspect early for better quality of life, treat early for the prevention of CV complications, engage in weight loss regime programs, especially sustained weight loss and behavioral therapy. PAP therapy is preferred as compared to surgical correction, especially in moderate to severe cases. Bariatric surgery can be considered early whenever it is indicated, and follow-up is really essential, especially when you're checking their compliance with the PAP therapy, which is most important. And you have to tell your patient that you have to use your machine for 4 to 6 hours in the night, especially during the later half of the night, when the deep sleep happens, when they have more desaturations out of this OSA. Thank you so much for your patience.
Thank you, Dr. Viny. Please come here. It is 10:12. And we need to now wind up at 10:35. So we have 23 minutes. So 11 minutes each for Dr. Vanita Arora's talk and Dr. Viny Kantroo's talk. So we first start with, please ask questions specific only to Dr. Vanita Arora. We put it on the YouTube, you know that. So it is easy for us to put the question answer session, one session by one session. And I go to Dr. Manu Saxena sir. He has the first question for us, only related to Dr. Vanita Arora's talk. No, Dr. Viny Kantroo's talk not right now. Anyone for Dr. Vanita Arora's talk? Yeah, Dr. Tulsi is there. Ma'am, I will just ask 11 minutes. I will take 2 minutes. Wonderful presentation on heart failure, advances in heart failure, ma'am. And you talked about the evolving role of beta blockers, MRSAs, and then ARNIs, and then SGLT2 inhibitors. There's something which I wanted to hear from you, and I'm very fond of. There is one drug which actually gives the best symptomatic relief, and that is a diuretics. What is the role of diuretics in heart failure today?
So the role of diuretic stands there in patients who get admitted to the hospital with worsening of heart failure for symptomatic benefit. You and I both know that diuretics do not give any mortality or benefit to the patient. They do not give, but they give quality of life benefit. So you have to measure it out. Once the patient is admitted, you give IV diuretics, you titrate them off. By the time you are discharging them, once you start these patients on RB, on SGLT2 inhibitors, on beta blockers, on MRA, subsequently MRAs, you have to decrease the doses of diuretics because you may be over-diuresing it. I have seen some patients coming to me who are over-diuresed. In fact, they start feeling weak. They are out of energy because we do not decrease the dose of diuretics and we keep on adding these drugs which give beautiful benefit to them. So diuretics stand there in acutely decompensated patients who come to the hospital for symptomatic benefit.
Ma'am, you mentioned about introducing, you said we like to introduce SGLT2 inhibitors and ARNI first, then beta blockers, then MRSA. What should be the ideal approach in a case of heart failure when we are dealing with an ejection fraction of 20%? Is it going to be step-by-step approach or a slam bang approach that you introduce all of them together?
So you are asking my treatment plan or what the guidelines say?
What the guidelines is? What is the guideline directed medical therapy, ma'am?
Yeah, guideline says you can, I gave the last chart, sir. The last chart says either you can start all of them together in case the blood pressure agrees. SGLT2 inhibitors you can start even if the blood pressure is on the lower side. But I have seen mostly people scared of starting ARNI and beta blockers in case BP is 90/60 or 100/60. I started. I'm not saying I do not start. I started. But I have seen people being scared or at 20% ejection fraction and BP being at 90/60. And what they do is they start ARNI at 50 mg twice a day, half BD. So this is no dose. You're practically not giving ARNI to the patient, right? So at least start at 50 mg twice a day. I would say start SGLT2 inhibitors. Okay, you're scared of blood pressure, start one of the two, ARNI or beta blocker, either of them. You start one of the two, wait for a week. If the patient doesn't have any symptoms, BP is still 90/60 on the tolerated dose, then add the next dose. So go by this stepwise approach, sir.
Absolutely, ma'am. Ma'am, the last question on your talk. Ma'am, there are so many agents that we are using, We are using MRSA, we are using diuretics, we are using beta blockers, SGLT2 inhibitors.
Yes, sir.
There is always a worry on account of kidney.
Yes.
And two things worry me. One is the electrolytes, potassium, and another is creatinine. So when you start using ARNI, what kind of a creatinine? Because you are using valsartan. And you are taking out something else, maybe ACE, ARB, which the patient was already taking, a gap of 24 to 36 hours, and then introducing ARNI. Now, when you start ARNI to this patient, what kind of a creatinine rise do you take as to be normal? And where do you say, okay, now I am not going to give everything to this patient, I'll be very careful. So, two things, creatinine and potassium. How to monitor when you are giving these multiple agents together?
Well, sir, in case we see the jump in potassium, it will occur in case we are giving ARNI and MR antagonist together. So I would withdraw MR antagonist for some time, and we will reintroduce them later on, maybe again. But ARNI I would continue, and creatinine, sir, in case it goes up to even 2. It increases up to 2. I wait. I keep continuing that. And sir, the improvement in GFR occurs in these patients. The creatinine does come down or stabilize at this level. It will either stabilize or it will start coming down. You just have to give some time to the patient.
Dr. M L Kalra's question.
Yes, sir, please.
Vanita, very wonderful talk. And I was amused to see that in 1983, when I did my MD, and 1993, when you did your MD, there was no change. Beta blockers still contraindicated, and adoption, and diuretics.
Yes, sir.
So, newer medicines, they are really wonderful. Just wanted to know one post I found in my one of the other groups. colchicine being used for heart problems, and probably it may be helpful in heart failure also. Have you used colchicine?
No, sir.
Okay, it's an anti-inflammatory.
Yes, sir. It is an anti-inflammatory drug.
It's also called gout. It was used for pericarditis, COVID also.
Yes, in the COVID also.
So it's an anti-inflammatory, and it has been, I found in the literature,
I
it
can't
can be
think
used
of it,
in.
but sir, I will look into it.
Yeah. One of the extension of questions of Dr. Chauhan here asked very wonderful question about beta blockers. Do we look for the heart rate also, or it is blind that we have to give?
Sir, beta blockers have two benefits. One of them is they control the rate, but if the rate is already controlled, which is unlikely, so there must be either a chronotropic incompetence in the patient or some AV conduction disease like left bundle branch block or something, that the rate is not increasing despite being in heart failure. Then beta blockers have to be used with caution. But they have two benefits. One is they control the rate, so you have slowed the speed of the heart to give a better cardiac output. Second, they have benefit for prevention of sudden cardiac arrest, which occurs because of the scar which is present there in heart failure patients, and they give you the benefit of survival. So these two things you have to
Only
analyze.
last two questions because we are meeting very less frequently.
No problem,
Just
sir.
about LPP pacing, as you said.
Yes, sir.
Is it about the division of the branch and bundle of pace, or where it is the place where you pace? Because the RS narrow will be only before the bifurcation.
No, sir.
Okay.
This is the interesting part. The hypophysis.
So you bypass
makes
this
sense.
one?
Yes, sir. We do electrical bypass.
Okay.
So what happens is we go to the HIS. HIS is at the junction of RA. It is in the RA, the right atrium, close to the tricuspid annulus. But there is a fibrous part of septum, which is in the RA. That is a 2 millimeter structure, which is the HIS. And then it extends into the RV also, the muscular part also, which is below the tricuspid valve. So you have to go into the RV for that part of the HIS. Now that divides into right and left bundle. Right bundle is very superficial. So left bundle is deep inside the septum. Now, once you have a left bundle branch block, so the block is distal actually. So if you just go and place the lead there, the flow of electricity will start in that bundle. So what we do is we go in the RV apex, and with the guiding, we have special guiding catheters. There's a long guiding catheter. We bring it back to close to the septum towards the tricuspid annulus, and we look for the left bundle potential. So we have to do the mapping. People who are doing without mapping are doing an incomplete work.
I think we went to more detail.
Yes, sir.
My last question is about cardiac contractility monitoring, modulators.
Yeah,
You
new
did-
thing which has cancer.
Dr. Tulsi sir, you have exactly 3 minutes, sir.
This is allowed. So, Dr. Vanita, let me say at the outset, it's always a pleasure to listen to you. So, the four foundational drugs,
Mic, please, mic.
shall I say, modifying drugs, or shall I say, prognosis modifying drugs, disease modifying drugs, SGLT2 inhibitors, beta blockers, MRAs, RAS inhibitors are now highly recommended as GDMT for heart failure. Now, can we use these drugs, or shall I say the SGLT2 inhibitors in acute heart failure? See, I am referring to the pioneer heart failure trial. So can we use these drugs, especially the SGLT2 inhibitors in acute heart failure? Tell us. And what about it? Acute coronary syndromes? Tell us.
So you already know the answer to the question. So acute heart failure, sir, they have shown promising results. But I would still stand that in case patient has come in acute decompensated heart failure, we have to give diuretics and look for the cause of acute decompensation. I mean, SGLT2 inhibitors are promising, but they will not improve the practical condition of the patient. You have to first give diuretics, remove the condition which has precipitated. It can be anything. It can be ischemia, it can be anemia, it can be infection, it can be arrhythmia, anything. You have to improve that. If you are able to improve that, yes. Once the patient little bit stabilizes, then start SGLT2. I start them early, sir. I do.
So, as you rightly said, pioneer heart failure, said you could use these drugs in acute heart failure. Now, let's proceed further with Dr. John's questions regarding hyperkalemia. See, the diamond study said at least 85% of the patients could continue this if you add a newer potassium binder like the petimomine. So these drugs are now safe to be used, especially if you add a newer potassium binder. And then what about the ACS? You didn't answer about the ACS, use of SGLT2 in ACS.
I'm not very convinced with that, sir.
You are absolutely dot on right. We should never use SGLT2 inhibitors in acute coronary syndromes.
I knew that answer, sir. I knew that.
In fact, in any acute events, not to use this because the risk of euvolemic, euglycemic ketoacidosis is huge. So don't use these drugs there. And what else? Dr. Chauhan is there, so diabetologist friend. So is the dual SGLT, I'm referring to the 1 and 2, the sotagliflozones, is it the icing on the cake for prevention of CVD and the renal events? Tell us.
I don't know the answer to this question, sir.
You answer it, sir.
One thing I want to say here, sir, I heard a lecture by Dr. Chauhan on SGLT2 inhibitors.
Yes, yes.
Best lecture I've ever heard.
I think Dr. Mangla, sir, Dr.
Let me complete.
With your permission, Dr. Mangla wants to interject just for a second.
No, I just wanted to ask, it's a common practice that as and when cardiologists are called to see a patient admitted under someone else.
Mike,
Acute heart failure. You write 80 milligram, 40 milligram IVTT as classes. And then they go. I'm asking when such patients are under your care, how often do you look at their IVTs regarding their fluid status? As you yourself said, that these patients are at times dehydrated. And regarding, creatinine of 2, do you continue with this, RD-like drug? I think people are scared. Second, as and when these beta blockers are added and the BP is 100 by 70, 90 by 60, they write Metax at 25 milligram. What is your beta blocker dose?
Oh, sir, too many questions. Okay, the first question, sir, you asked me was about. I never write 80 milligram 3 times a day Lasix. First of all, that. Okay, maximum we can go up to. I go up to is 40 milligrams twice a day. And that also after doing an echo, seeing that there is a, that IVC is full and ejection fraction is on the lower side and the volumes are on the higher side, right, sir? And then Lasix, in fact, now has to be given even in diastolic heart failure for symptomatic benefit, in case the patient lands up in acute heart failure. Secondly, about the creatinine you said. So creatinine, the rise of creatinine does occur. Many patients I have seen it occurring. And I have my nephrologist friend who tells me to wait for about week or 10 days on the same dose of RB, and the creatinine, if it stabilizes, we are good. Otherwise we can withdraw the drug for some day, but he makes me try again. After a gap of 3 to 4 weeks, he makes me try again. Go ahead, give RB now again. So it is very interesting to see that even if once the creatinine goes up, you try giving this drug again to the patient, the creatinine settles down.
Another important thing,
Yes,
ma'am, is that if you keep over-dialyzing the patient. The creatinine doesn't come down. So that is very, very important.
That balance has to be done, sir.
So
We have to be very careful.
You
not
need
use
to
the diabetes.
down-regulate the diabetes to get to the correct and true creatinine value.
Absolutely.
Do not estimate the creatinine value if you are giving a dose of 80 milligrams twice a day. No, it's not good. It's not
How
good.
often do you look at the IVCs?
Sir, I do. In ECHO, of course, we do
Once
that.
a day.
Yes, not every day, sir.
Every time.
Not every day. Once the patient is admitted, we do it. Then we are, of course, taking
After
care of.
diuretic, when you look at the IVCs, whether you need
Sir, you have to go according to the urine output and the weight of the patient.
Sir, Dr. Tulsi sir, last question to Dr. Vanita. We need to move the next topic.
Absolutely, the very last question. So, Dr. Vanita, we talked about the door inhibitors, the cherry on the cake. Cardiorenal protection, a recent meta-analysis of 16 RCTs involving more than 20,000 patients said that SOTA has a clearly shown CV benefits and renal benefits. This is a meta-analysis of over 20,000 patients. So this is the cherry on the cake. Thank you.
I think, sir, we want to wind up the first session to Dr. Vanita Arora start right now because we need to give at least 8 to 10 minutes to Dr. Viny Kantroo also. Ma'am, wonderful presentation. We're sorry you had to hurry up in the end, but it is such an important topic and something which was considered to be a joke about 20 years ago is now supposed to be the most important disease that a person can have. Dr. Mangla often says, if you know your diabetes, you know your medicine. And I say, if you know your OSA, you know your medicine completely. Because it involves everything. Ma'am, for a common physician, in our practice, how do we suspect OSA?
So it's very, very simple, sir. You have a large chunk of diabetic patients coming on to you who are obese. So if the BMI is high, patient has been diabetic, as I showed you, for over a decade, wherein the hypertension is not getting controlled with 3 medications. And the look of the patient is very, very peculiar. They enter your OPD, you will see that the patient is not engaging much in the conversations which you are doing. He's just, kind of busy, wanting to go on to sleep and inattentive. So the look is very, very peculiar. They have a large tummy, their BMI is high, they have been diabetic, they're uncontrolled hypertensive, the insulin resistance is going high. Therein, you can settle and ask them proactively these questions whether you are getting excessive daytime sleepiness and excessive fragmentation. Even getting up during the night for urination is one of the symptoms which OSA can present as because of the fluid shifts which happen in these kinds of patients. So these are very, very important questions which you need to ask them.
Ma'am, you mentioned about the criteria of slope band.
Yeah, definitely.
Is witnessed apnea another thing that is extremely important for the diagnosis?
So witnessed apnea, if the partner is telling you that in the night I see that his breathing goes down and he gets up during the night to take a long breath, 80% of the time that patient might turn out to be your OSA patient. So this is one of the most specific symptoms which you rightly pointed out, the witnessed apnea which happens. Sometimes if you are in a resource limited setting, you don't have a patient who will afford your sleep study. What you can do is ask their partner to put in a pulse oximeter on their finger during the night, during these episodes, and if they tell you the saturation also goes down, then you can upfront start the CPAP for this patient and look out for the decrease in the symptoms if of course they are not able to afford your sleep study.
Ma'am, you mentioned polysomnography is the gold standard test to diagnose. How much does polysomnography cost in your setup?
So a polysomnography in my setup, which is the level 1 study, it is monitored by a sleep therapist or a sleep technician. It would be costing around 30,000 in my setup. That is because of the corporate setup, they charge you for the room and everything. But if I think Dr. Mangla will agree that in a reasonably good center, these days we are charging around 20 to 25,000.
If the patient says, ma'am, I have a very good room, I live in a bungalow, you do it at my home, then what do you charge?
If my retest probability is very, very high, I'm sure that he's going to be coming out to be OSA patient. I'm not suspecting anything like OHS. and I'm not suspecting him to be a heart failure patient who can have a problem at home with these desaturations. They are not in acute hypoxia wherein I need a monitored environment like in an ICU kind of a setting. If the patient is not suffering from any acute disease, I can go in for the home study. That can very well be done. What I don't like about these studies is the auto PAP which is prescribed. You know, the auto CPAP which is prescribed, it has a lag response. Auto is something which senses your level of apnea and gives you the pressure according to your apnea, but it has a lag in sensing that and giving that much pressure. So that is what I don't like about it. I tend to prescribe fixed pressure wherein the patient is getting the benefit of that fixed pressure for the whole of the night. So auto CPAP, if that is taken out of these home studies, I am with a high pretest probability, I am okay to have the level 3 and 4 studies.
Then you mentioned about the neck circumference, and you said the threshold of 40 centimeters. Is it the absolute neck circumference or retropalatal area which is more important?
So it is basically the neck circumference, whole of the
That is good enough.
collar size, yeah.
That is good
Sometimes we do tell the patient, we ask them their shirt collar size, which also correlates with the neck circumference.
Dr. Mangla, say on whatever you said, and maybe some very important inputs.
We have had a very detailed talk on this subject. The only thing is that after having done everything, the acceptance of this mask is not very high. We tell our patients that, you see as and when you wear your spectacles, but here you wear your spectacles and enjoy for 16 hours. Those patients who are really rewarded, I came across a lawyer who says when my turn is coming, I don't sit down because I know I will fall off. I keep on standing. That is the risk these people have. And once the patient is convinced, his lifestyle changes because their mental faculties are going down. So these patients, when they are going out, they put their toothbrush and paste later and keep their CPAP first. So that is the relevance of this. Thank you.
Sir, Dr. Tulsi will have a question, and we are going to wind up the session after that. Just a minute. Dr. Tulsi's last question. Dr. Saxena sir, you can ask question on the dinner, sir. We need to respect, sir. We need to respect. A lot of people leave without dinner, sir. Please.
The very last one. So, Dr. Viny, that was an excellent talk. So, are there any variable markers, biomarkers that you would say are there which would probably identify OSA?
So at present we don't have a specific marker like PCT in case of sepsis, bacterial sepsis. However, there are certain markers which could be representative of your metabolic syndrome per se. For example, these patients might have a slightly higher CRP and ESR value, which are the common markers.
IL6, IL8, inflammatory markers may be higher.
Yes.
And then, what about the setting of the CPAP? You say about you set initially at 8 to centimeters, 8 to 10 centimeters, and then probably increase further. And would the nasal CPAP be better than the mask which Dr. Mangla talked about?
So what we do in the split night study is we also see how they fare on the various levels of pressure. We start in from 4 and we go by increase it by a factor of 4 and we go till they are controlled in the supine position in REM sleep also. When they don't have desaturations in the REM sleep happening in supine position, that is what the pressure we are aiming at when their apnea is getting correction. If it is a
He's concluding.
so if it is not being done that way, we are not doing the split night study. It is just hit and trial method which you are trying with your patient. You are seeing the number of apneas which are happening, and then you start in with 10 and then you follow the card method which is there in the machine. You see their apnea, hypoapnea index. If they are still not controlled, you will increase the
Nasal CPAP.
But nasal CPAP, we do try on lower pressure, but if the pressures are higher, the leakage happens more often in these kind of patients. So more than 12 is the face mask which I would do.
Thank you, madam.
Thank you. First question.
Sir, Dr. Kantroo sir, just a minute. Sir, please. I give 1 minute to Dr. M L Kalra sir to wind up the first session. Another 1 minute to Dr. Mangla sir to wind up the second session. And you are free to ask any questions, sir. Please. We need some time.
सर, मैं थोड़ा स्वैप कर रहा हूँ। मैं डॉक्टर मंगला को मेरा करने के लिए कहूँगा। मुझे याद आ गया 10 साल पहले मुझे चेयरपर्सन बनाया गया था OSA पे। तब मैंने खड़े खड़े एक 4 लाइनें लिखी थी, जब मधुर नींद की साइकिल के कुत्ते फेल हो जाते हैं। किसी ने कुत्ते देखे हो साइकिल के, मुझे नहीं पता। हम सोते हैं पर सोते नहीं और कहीं भी कभी भी सो जाते हैं। So that was my